Hello everyone, I'm Anas Al-Ubaidi, and the topic or the title for this session is Chronic Pain and Autoimmune Disease Documentation within Chapter 31, which is about review of endocrinology and rheumatology scribing within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. Chronic pain is a pervasive health challenge that affects millions globally, worldwide, often requiring extensive medical interventions and careful documentation. When chronic pain intersects with autoimmune diseases such as rheumatoid arthritis (RA), SLE, systemic lupus erythematosus, or multiple sclerosis (MS), the complexity of documenting these conditions increases exponentially. For medical scribes, mastering the nuances of documenting chronic pain and autoimmune disease is critical for maintaining accurate medical records, facilitating clinical decisions, and enhancing patient outcomes. Chronic pain differs from acute pain in that it persists beyond the typical healing period, often becoming a disorder in its own right. It may inadequately respond to traditional pain relief measures and frequently affects the patient's quality of life, emotional well-being, and ability to work. Capturing this complexity requires documentation that extends beyond physical symptoms to include psychological and functional impacts. For example, documenting a patient's inability to perform daily activities due to persistent lower back pain provides important context for therapeutic interventions. Autoimmune diseases, on the other hand, are characterized by the immune system erroneously attacking the body's own tissues, leading to widespread inflammation, organ damage, and disabling symptoms. Each autoimmune condition has unique manifestations, but they share a systemic nature that makes diagnosis and management intricate. Accurate documentation is especially important here, as autoimmune diseases often involve multi organ systems, episodic flares, and overlapping syndromes that can lead to diagnostic challenges. For instance, a patient presenting with joint pain and skin rash could have lupus, rheumatoid arthritis (RA), or even psoriasis related arthritis, each requiring distinct management plans. Key points. Chronic pain documentation. Detailed symptom documentation. Documenting chronic pain requires capturing subjective and objective details that paint a clear picture of the patient's experience. Key elements to include are location and nature of pain. Record if the pain is localized or diffuse and describe its nature, for example, aching, burning, stabbing. For example, patient reports sharp stabbing, lower back pain radiating to the left leg. Onset and duration, note if the pain began following an injury or surgery and its persistence over weeks, months, or years. Pain intensity and frequency. Use patient-reported scales like pain rated 8 to 10 on the visual analog scale VAS, and whether it is a constant or episodic. Aggravating and alleviating factors include details such as pain worsens with prolonged standing and improves with rest. This level of detail helps providers tailor treatment strategies and monitor effectiveness over time. And here's a diagram on chronic pain documentation. Impact on daily function. And chronic pain often significantly impacts function and quality of life. Document how pain influences activities such as mobility. Patient reports difficulty ascending stairs due to knee pain. Work, missed multiple work days in the past month due to migraines. Sleep patterns, experiences disrupted sleep 4 to 5 nights per week due to pain flare-ups. Including these details provides essential context for understanding the holistic effects of chronic pain and justifying interventions. Pain management treatments. Record all attempted or ongoing management approaches, their outcomes and potential side effects. Medications. Document prescriptions, dosages, and patient adherence. Example: prescribed gabapentin 300 mg daily for neuropathy. Interventional procedures include treatments like epidural steroid injections or nerve ablations, specifying dates and results. Physical therapy. Not frequency and goals, for example, improving range of motion. Alternative therapies include alternative methods like acupuncture or CBD use with patient-reported effectiveness. Highlighting the multidimensional nature of treatment emphasizes the complexity of chronic pain management. Red flags for escalation, identifying and documenting red flag symptoms ensures timely intervention. Examples include severe, rapidly worsening pain unresponsive to medication, neurological deficits like numbness, weakness, or loss of bowel, bladder control, signs of dependency or resistance, such as frequent requests for increased medication dosages. Proper documentation of these symptoms helps prevent delays in advanced evaluations. And here is a diagram on prioritization of red flag symptoms. Autoimmune disease documentation, comprehensive symptom assessment. Autoimmune diseases present with varied symptoms that require meticulous documentation. General symptoms record fatigue, fever, and or unintentional weight loss. Common systemic manifestations of autoimmunity, example, patient reports daily fatigue affecting ability to work since January. Joints and muscles, not swelling, stiffness, or pain, or often symmetrical, as in rheumatoid arthritis, RA for short. Skin and mucosal changes include signs like butterfly rash across cheeks, lupus, or skin thickening scleroderma. This documentation aids in identifying patterns that point towards specific diagnoses. Diagnostic and laboratory findings provide detailed documentation of autoimmune specific tests and their interpretation. Autoantibodies document ANA, RVF, or anti-CCP results. Example, ANA positive at 1 to 320 titer homogeneous pattern. Inflammatory markers include ESR and CRP levels as key indicators of disease activity. Organ-specific tests, for example, recording degrees complement levels, C3, C4 in lupus, or hypercalcemia in sarcoidosis. Comprehensive records align clinical assessment with objective data for clear diagnostic pathways. Disease progression and patterns. Autoimmune conditions behave dynamically with periods of remission and flare-ups. Scribes must capture these patterns to guide treatment. Document symptom recurrence, frequency, duration, and triggering events, for example, stress infection, include statements like symptoms worsening for 3 weeks with increased joint stiffness and morning fatigue lasting 4 hours. This data ensures treatments are adjusted appropriately. Treatment and response documentation includes specifics of ongoing and past treatments. Medications accurately record immunomodulators, for example, methotrexate, plaquenil, or biologics, example, adalimumab, as well as side effects like GI distress or fatigue. Steroids, not prednisone or prednisolone, use and tapering protocols. Procedures include plasma exchange transfusions, or surgeries, detailing outcomes like symptom relief, highlight patient compliance and response for a full clinical picture. And here is a diagram on autoimmune condition management sequence. Complications and red flags. Careful attention to complications helps mitigate risks. Severe flares document acute crises like lupus nephritis with proteinuria or an interstitial lung disease in scleroderma. Secondary conditions include opportunistic infections due to immunosuppression, organ damage, for instance, chronic kidney disease secondary to autoimmune nephritis. Prompt documentation signals the need for specialist interventions when complications arise. Next, we have summary tables. Here we have table on key chronic pain symptoms and their documentation, table on common autoimmune disease symptoms and patterns, table on diagnostic tools and their significance, table on treatment approaches for chronic pain and autoimmune diseases, table on key red flags for chronic pain and autoimmune disease documentation, and next, we will revise what we have covered through this lecture via some MCQs or multiple choice questions. Question 1. Which key detail is most important to document when assessing chronic pain? A. The patient's diet preferences. B, the social support system of the patient, C, the location, duration, intensity of the pain, or D, the frequency of the patient's appointments. Definitely it's C. As chronic pain documentation should focus on specific pain characteristics such as location, duration, and intensity. These details provide insights into potential causes and guide management strategies. The other options, while relevant to overall care, are not primary considerations for pain assessment. Question 2. What laboratory test result is significant for diagnosing systemic lupus erythematosus, SLE? A. Positive ANA anti-nuclear antibody with high titer. B. Elevated fasting glucose. C. Decreased TSH. Or D. Negative rheumatoid factor RF. It is A. The positive ANA. A positive ANA test with a high titer is commonly seen in systemic lupus erythematosus, SLE. It indicates autoimmunity, while RF is relevant for diagnosing rheumatoid arthritis and glucose for diabetes. These are not primary markers for lupus. Question 3. Which of the following symptoms suggests a flare-up of multiple sclerosis, MS? Is it increased lymph node size? A. B. Sudden onset vision changes and limb weakness. C. Persistent fever and joint swelling. Or D. Slow healing skin abscess. And it is B. As neurological symptoms like vision changes, limb weakness, or sensory loss often indicates MS, multiple sclerosis flare-up. These symptoms arise due to inflammation and demyelination. Fever and joint swelling are more indicative of autoimmune diseases like lupus or RA rheumatoid arthritis. Question 4. What is the primary goal of disease-modifying anti-rheumatic drugs in autoimmune disease management? A. To alleviate fatigue and improve appetite. B. To provide immediate pain relief during disease flares. C. To slow disease progression and reduce inflammation. Or D. To permanently cure autoimmune conditions. So the answer is C, as to slow disease progression and reduce inflammation. So C is the answer, as DMARDs, which is short for disease-modifying anti-rheumatic disease, DMARDs, are prescribed to slow the progression of autoimmune diseases like RA and lupus, decreasing inflammation and joint damage. These drugs are not for immediate pain relief or curing diseases, as autoimmune conditions typically require chronic management. So it is not D, definitely not D, which is to permanently cure autoimmune conditions. So the answer is C. Question 5. Why is it crucial to document rapidly worsening joint swelling in a patient with rheumatoid arthritis? A. It indicates a possible allergic reaction. B. It may signal an infection or significant inflammation requiring escalation. C. It is a normal progression of RA and needs no action. Or D. It helps track physical therapy progress. So the answer is B. It may signal an infection or significant inflammation requiring escalation, as rapidly worsening joint swelling in RA could indicate a severe inflammatory disease or even joint infection, necessitating immediate medical attention. It is not a typical progression of RA and requires careful documentation for timely intervention. And here we come to the end of this lecture. Thank you very much and goodbye.